Good morning and welcome to the second webinar of the year, the second webinar that we are organizing as a Europe Direct core platform. This year, our webinars are focusing on Malta's Recovery and Resilience Plan, a topic which we discussed during one of our webinars last year. And this year, we'll be looking at the different aspects of the Recovery and Resilience Plan. Today, we will be focusing on the component relating to health. And in fact, the topic of today's webinar is strengthening the resilience of the health system. And once again, to share their knowledge and their expertise on the topic, we have with us a very esteemed panel of guests. I would like to welcome Ms. Laura Peter, who is a policy officer within the DG Sante at the European Commission. Also with us is Mr. Ben Rizzo from the European Economic and Social Committee. We also have Dr. Chris De Guara today representing the Malta Chamber of Commerce, Enterprise and Industry. Dr. Anthony Gatt, who is a consultant public health medicine within the Office of the Chief Medical Officer in the Department for Policy in Health. And last but not least, we also have Ms. Helga Alul, who is the President of Core Platform, which is the host institution of our Europe Direct Center. Good morning, everyone, and thank you very much for accepting our invitation. And I would like to invite you, Helga, to start off with your introductory remarks.
Well, good morning to you all. As Roberta already outlined, the work of our Europe Direct core platform is to inform the citizen out in Malta here about European programs and initiatives that have an impact on their lives and on their businesses. As part of these activities, initiatives, Europe Direct core platform is organizing these various webinars, and they are focusing on Malta's Recovery and Resilience Plan. Now, we had the first webinar held in the last quarter of 2021, which provided actually a detailed overview of the plan. And this year's webinars now will be focusing into each of the 6 pillars of the plan in further details to see what's actually happening. Malta's plan is based on 6 main components. Now, our first webinar, which was held on the 16th of March, was titled Fostering a Digital, Smart and Resilient Economy. But today we are focusing on component number 4, which is strengthening the resilience of the health system. In 2019, the Council's recommendations on our National Reform Programme of Malta stated actually regarding healthcare measures to decentralize services from hospitals to primary care and to improve the provision of long-term care services are ongoing. The current plans to expand the capacity of public hospital outpatient care can help in tackling the long waiting times for certain specialties. But nevertheless, other measures to reduce unnecessary referrals to specialists and redirect inappropriate use of emergency care to outpatients have so far not been fully used, so preventing actually improvement in efficiency of the system. A new concept for primary care centers and investments to gradually expand the use of health are carried out with a view of to decentralize the service from hospitals to primary care level. Reflecting increased demand for long-term care, new types of community-based and home care services were introduced in 2017 to 2018. But despite the potential, the impact of the measures in this area of pensions and healthcare on fiscal sustainability has yet to materialize. In 2020, recommendations, on the other hand, states the following. The Maltese healthcare system delivers good health outcomes. However, the outbreak of the pandemic put the Maltese public health system under unprecedented levels of pressure. Efforts to focus on building the capacity of the healthcare systems to respond effectively to the pandemic crisis would improve its resilience. Now, the following areas require particular monitoring. The increasing reliance on migrant nurses in acute and long-term care and an aging private general practitioners workforce may pose challenges. The difficulties in making new and innovative medicines available. The high out-of-pocket expenditure on primary and outpatient care and on some medicines. Waiting lists for outpatient care specialties are consistently long and have been increasing recently. Reorientating service delivery away from hospitals to primary care remains also a key priority. The 2019 recommendations therefore included, in the earlier, ensuring the fiscal sustainability of the healthcare system, whereas the 2020 recommendation focused around strengthening the resilience of the health system with regard to the health workforce, critical medical products, and primary care. The reforms and investments being proposed under the Malta recovery plan reflect this recommendation. So I'm looking really forward to a fruitful discussion to fully understand the reforms and investments underway, and also how the different stakeholders can work together to ensure a positive outcome. Looking forward to your discussion. Thank you.
Thank you so much, Helga, for that introduction. I believe you've given us the context within which now the reforms and the measures have been proposed and the way that they're going to be implemented. And as you said, we look forward to the discussion. But before that, I would like to invite Ms. Peters from the European Commission, who will be delivering a presentation on the European health system's resilience in the face of the COVID-19 pandemic. So I give you the word, Laura. Good morning.
Good morning. Many thanks, Roberta and Helga, for the nice introduction. And yeah, I'd really like to start from a quite broad view on the EU level and then come to the Maltese healthcare system and challenges. And therefore, I'd like to ask my colleague Kalen to show my slides. So here we are. Yeah, I'd like to give you an overview of the so-called state of health in the EU project, but which also feeds in the European semester in the field of healthcare. So this is really an infrastructure to make health systems, information, expertise as easily accessible to everyone. So the objective is to strengthen the evidence base on health systems performance for policymakers, stakeholders, researchers, and also the general public. The project is run by the European Commission in close partnership with the OECD and the European Observatory on Health Systems and Policies. And the cycle always kicks off with the so-called Health at a Glance Europe, which is a publication drafted by the OECD, and then follows in the next year by the country health profiles and the companion report. And the country health profiles are usually drafted by the OECD and the Observatory. Based on these country health profiles, the European Commission drafts the so-called companion report, which is really a accompanying document and has the idea to showcase a selection of cross-cutting issues drawn from the country health profiles. So yeah. Thank you. Next slide. Yeah, the country health profiles usually give an overview of the health status in one country, but also look at the health system's performance. And in the last edition, of course, also the performance and resilience in the view of the COVID-19 pandemic. And the idea is to give policymakers and stakeholders an overview or snapshot of the key strengths and challenges in the health system, and also a comparison with other EU countries. So as I said, the focus in the last edition is really, of course, the impact of the COVID-19 pandemic. So next slide, please. And the companion report based on the country health profile has three main takeaways that I want to highlight today. The first one is understanding the far-reaching impacts of the COVID-19 pandemic. The second one looks at the advantages of digital innovations in healthcare delivery as well as in public health. And the third one is rethinking the health workforce strategies and planning after the COVID-19 pandemic. So the objective of this report is really to act as a bridge between the data and analysis presented in the country health profiles and the various relevant policy initiatives and support instruments by the European Commission. Next slide, please. And to directly kick off with the first topic, the health impacts of the COVID-19 pandemic, we really tried to better understand the true toll of the pandemic on health. And the first step is to look at life expectancy. And we have seen a steep decline in life expectancy in many EU countries, and this steep decline completely erased in many countries, at least temporarily, almost all gains in life expectancy since 2010. But I'd really like to highlight at this stage already that Malta performed much better in this field than most of the other countries, because the loss in life expectancy was much smaller than in other countries. Okay, next slide, please. Since the start of the pandemic, 1 in 10 deaths in the EU was registered as a COVID-19 death. But we also know that this might be an underestimate for several reasons. For example, due to limited testing capacities and also issues with the case of death registration. And therefore, we look at the so-called excess mortality, which has the idea to measure the number of deaths reported beyond what we would normally have been expected based on a historical baseline from several years. And then we see that the excess mortality was 12% higher than the reported COVID-19 deaths. And when we have a look at the map of Europe, we also see that this excess mortality is quite unevenly distributed across Europe, with much higher levels of excess mortality in the Eastern European countries. Next slide, please. But of course, we know the pandemic is still ongoing. We still have very high numbers of COVID-19 in a lot of countries. And yeah, of course, it's important to also look at the other effects of the COVID-19 pandemic. So we had a lot of forgone care and misdiagnosis in non-COVID care, for example, for elective surgery, but also in the field of cancer, and postponed services and treatments, and actually long waiting times for certain services as well. And another important point to mention is the huge impact on people's mental health due to social distancing and lockdowns, for example, but also the burden of the post-COVID-19 condition will keep the health systems busy in the future as well, not only for the time being. So in summary, we can say here that the number of COVID-19 cases and deaths only provides an incomplete picture of the health impact. And the question is really, how can health systems adapt not only to address these short-term effects, but also to address long-term effects of the pandemic? Yeah, thank you. Then let me come to the second takeaway, the locking in the advantages of digital innovation in healthcare delivery and public health. Of course, we have seen in the course of the pandemic a massive acceleration in the take-up of digital health tools, especially in the field of telemedicine. And we have also seen a boost in public health. So during the pandemic, we used tracing apps, and also a big topic was the EU digital COVID certificate, where you can see the vaccination stages and test and recovery stages, and also across borders. It was usable. It is still usable, of course. And but the important thing is, of course, that these innovations will require a thorough and comprehensive evaluation to see what is relevant and needed for the future needs. Next slide, please. Because all these all these ideas and innovations were coming from a necessity in the implementation. So looking beyond the pandemic, countries need to reflect on how digital health technologies should be readjusted to serve a broader set of objectives. And therefore, we also need to ask, how can we incentivize the use of these technologies in a non-emergency case? And another important point is also to minimize the risks of widening health inequalities through digital exclusion, especially for vulnerable groups, of course. And there is still a need to invest more in the implementation and maintenance of infrastructure and equipment. And I'd like to mention the Commission flagship initiative here, the European Health Data Space, what gives access and exchange of health data on the one hand to healthcare providers and patients, but on the other hand also gives data to research and policy making. Next slide, please. The next point is the rethinking of health workforce strategies and planning after the COVID-19 pandemic. And this slide is really to give you the starting point. So we can see that the doctors and nurses are really, we have different ratios and numbers across European countries. And we actually don't know what is the optimal ratio or the optimal number of doctors and nurses. But of course, we can say that if both numbers are low, it's difficult for a health system to adapt and to deal with crisis. And when we look at the map of Europe, we can see again that we have an uneven distribution, not only across Europe, across countries, but also within countries and across regions. So of course, it is not a new problem that we have health shortages or workforce shortages, but they were brought to the spotlight due to the pandemic. And health systems developed certain strategies to expand the number of health workers. For example, by bringing in medical students or retired doctors to the systems. But the already existing health workforce in the system were really brought to their limits. On the one hand, because they had a higher exposure to the virus and had a higher risk of being infected themselves, but also because of the whole stress, there was a huge impact on the well-being and mental health of health workers. And we hear alarming numbers really of people leaving the profession. So it's really important to stress again that a well-trained, motivated health workforce of appropriate size and compensation is a crucial precondition for building resilient health systems. So the companion report tries to give some ideas and solutions on this topic. The one thing is to implement a better workforce planning. And this also includes the improvement of working conditions, financial and non-financial, to forecast the better forecast of future staff needs, and also to increase, of course, the investment in training and education. And the third thing is to incentivize the adoption of skill mix innovations, for example, task shifting, but important to stress here that it's not for a substitution of workforce, but to gain efficiency for better allocate the already existing workforce. And one example I'd like to mention here is a joint action on workforce planning that the Commission has launched under the EU for Health program. Next slide. And to give a general overview of the Recovery and Resilience Facility, which is, of course, one answer of the Commission to the crisis. The aim is really to mitigate the economic and social impact of the pandemic and make European economies and societies more sustainable, resilient, and better prepared for future challenges. And the Recovery and Resilience Plan invests more than 320 billion euros in loans and grants in the European economies. And I think Helga already mentioned it, of course, that health resilience is among the 6 main pillars of the RRF. And to give you maybe in a state of play, till now the Commission has adopted 24 national recovery and resilience plans, and the Council approved 22 of them already. So 2 will follow soon. And out of these 22 already approved recovery and resilience plan, 37 billion euros will be spent on health, which is 8% of the total expenditure there. Next slide, please. I'd now like to come to the Maltese country health profile and the key challenges due to the COVID-19 pandemic in Malta. So next slide, please. I'd like to start a bit with an overview of the health status. So this is an overview of the main causes of death in Malta. So maybe relevant to mention that the COVID-19 value comes from 2020 and the other numbers come from 2018, since we had no more current data when the country health profiles were drafted. So it is, we can see that, maybe back, please. Cardiovascular diseases were responsible for 34% of all deaths in 2018, and cancer accounted for another 28%. And in 2020, COVID-19 officially accounted for a bit more than 5% of all deaths, but as I already explained before, this might be an underestimate as well. So next slide then, please. The next slide I'd like to show you is an overview of the risk factors that are showcased in the country health profile. So to maybe a small explanation on the graph itself, it means that the nearer we are with one point in the center of the circle, the better is the performance in this field compared to other health systems in the EU. So a big challenge in Malta is indeed obesity. So the rates of obesity in Malta are the highest in the EU, with more than 1/4 of adults classified as obese. And yeah, of course, poor diets and physical inactivity contribute to high levels of obesity in the country. And in general or overall, we can say that over 1/3 of all deaths result from behavioral risk factors. So it is, of course, still important to strengthen public health and prevention, but yeah, of course, it's on the political agenda, as we know. Next slide, please. This is to showcase the health expenditure and also the share of public funding, and there we can see that the share of GDP as well as the total spending on health is lower in Malta than the EU average. And what is also interesting or important to mention, that the share of public funding in Malta is quite low compared to the average, but also compared to other tax-funded healthcare systems. But also, I'd like to mention that Malta saw a substantial increase in public funding for health during the COVID-19 pandemic, with an additional 130 million euros committed to the health sector in 2020. The majority of this funding was allocated to procuring PPE, critical care, beds and other medical equipment, as well as to increase the numbers of health workers during the COVID-19 pandemic. We also see quite low investments in prevention. And another key objective next to strengthening prevention is also to strengthening primary care. Means on the one hand, shifting health service delivery to primary care for cost-effective reasons, but also to strengthen the management of chronic conditions. Next slide, please. another topic, I think it was also mentioned by Helga in the introduction, that the level of out-pocket spending is quite high in Malta, with the high share is driven on the one hand by direct payments for privately purchased primary care and outpatient specialist care, but also the out-of-pocket spending on pharmaceuticals and long-term care is also high. But interesting to mention here that the levels of unmet needs in Malta are really low compared to other EU countries. Next slide, please. This is the graph you've already seen, but just to show you where Malta is compared to the EU average there. So we see that Malta has a slightly higher density of physicians in the EU compared to the EU average, and the density of nurses is slightly below the EU average. But yeah, what we see that there are shortages in certain specialties, and hospitals are really reliant on foreign trained nurses, the same for long-term care. And another challenging point is really the recruitment and retention of GPs, since this number is declining since 2009. Okay, next slide, please. And when we come to the resilience of the pandemic, there were, of course, structural weaknesses in the health sector, prompting rapid responses. But of course, this is the case for all health systems in the EU. So it's not only Malta, of course. But to mention specifically for Malta, maybe workforce mobilization on the one hand. There were several strategies to increase the capacities during the pandemic, where professionals were redeployed to other settings, or early graduation of final year medical students and nurses to assist healthcare professionals. And another point, volunteers who were recruited to assist professionals or to answer the COVID-19 helplines. There was also a rapid rise in the use of digital health tools to promote access. For example, the use of remote consultations in primary care really increased and helped to ensure the continuity of care. There is a special telemedicine hub for primary care that was established during the pandemic. And of course, e-prescriptions and electronic submissions of sickness certificates were used much more than before. But on the other hand, Malta entered the COVID-19 pandemic with limited hospital capacity. And major restructuring in recent years has seen the number of acute and long-term care beds in Malta fluctuate. And the occupancy rates of acute care beds before the crisis were frequently ran at over 18%, which is among the highest rates, one of the highest rates in the EU. But rapid action was taken during the pandemic to expand hospital capacity, especially intensive care beds. Next slide, please. So to improve for the future, their investments especially aimed at certain areas, as mentioned, in prevention activities and strengthening primary care, but also in health facilities, in infrastructure like the so-called pandemic reserve, and also the development of an outpatient building at the Mater Dei hospital, and the modernization of health centers and community clinics all across the country. And another big point, of course, digitalization in health. So it is planned to establish an integrated electronic patient record across primary care. And all these topics are funded on the one hand by the national budget, but also by EU funds, for example, by cohesion funding. And then another point, which is also the big topic today, by the Recovery and Resilience Facility. So next slide, please. So I'd just like to give you a short overview then about the Maltese Recovery and Resilience Plan. It has a total budget of 316 million euros, and around 70 million are health related. But we can subtract 20 million, since they will be used for the roof topping and renovation of a hospital to make it more climate efficient. So the big health topic is component 4, strengthening the resilience of the health system, with around 50 million euros. Next slide, please. And this component consists of several measures. The one is the development of a workforce planning tool to prepare better for the future regarding workforce. Another big point is to improve the well-being and integration of foreign health workers. There is a survey, and afterwards it will be seen how the survey will feed the strategy to improve the well-being and integration. There are several measures to enhance the disease prevention to children's health, for example, also in the field of obesity. And the biggest investment is for the establishment of a blood tissue and cell center in Malta, also linked to the review of the legislative framework. And another big point is the digitalization and new technologies, such as a new magnetic resonance linear accelerator, which is the biggest investment in this field. Next slide. So that's already it from my side. I just highlighted here, or want to give you the web pages that will be accessible afterwards. The one state of health in the EU, there you can find the companion report as well as all country health profiles. And under the recovery and resilience webpage, you can find the general explanation on the RRF, but also the links to the national recovery and resilience plans. So many thanks for your interest.
Thank you so much, Laura, for that very comprehensive snapshot of what's happening across the EU, the challenges that we are facing as a country and also as a continent, and then also zooming in on the actual reforms and investments that are being proposed and are underway, I understand as well, in order to meet these challenges. So thank you very much for that. I would like to see, before we kick off the panel discussion, I would like to ask if there are anybody who would like to react to anything that was said in the presentation. No. Yes, I have Dr. Gad.
Yes, good morning to you all.
Good morning.
Thank you for this opportunity, and thank you, Laura, for the detailed presentation. I noticed that during the pandemic, the Maltese mortality was not as high as the other countries. I don't know if there are any studies that might indicate what is the reason for this. We are happy, of course, for this, but it would be perhaps that we took more stricter controls, and especially in the first year of the pandemic. Maybe our lockdown was more intense. I don't know, but I'm happy that this is the result of our actions. The pandemic has resulted in a remarkable transformation of our services from being basically paper-based or a simple Excel sheet, so to speak, to increasing digitalization of our COVID-19 response. And recently, I think in December, a new IT system was launched. It was built up over several months. And this IT system is now covering basically all the different fields of the COVID-19 response, from case management to contact tracing and discharge, as well as data management. And it has proved of immense help in the sense that this system is facilitating much of our work. It has enabled most or many of the public health consultants and resident specialists, etc., to return to their pre-COVID work, which obviously was delayed, as you can understand, and we hope that in the next few weeks and months, the rest of the public health team will return to pre-COVID work. We should put this into perspective in the sense that the national public health response was managed solely by the public health officers within the government service. And I'm saying this because we realize when we compare with our colleagues in other EU countries, especially the larger countries, where the response was managed more locally in each different region, towns, or whatever. Whereas we had the burden of reacting to this unexpected pressure of work and control and prevention of COVID-19. I think for me, for now, it's enough. Thank you.
Thank you, Dr. Gatt, for your observations. Ms. Peters, I don't know if you would like in turn to comment on these observations.
Yeah, thank you already. Yeah, it's always, of course, interesting to hear how people from the national health authorities see this on the ground. But yeah, actually, you're absolutely, or I totally agree that there was a huge development in the health systems in the field of digitalization and healthcare delivery. So I think Malta is really one of the better performers in the course of the pandemic. But I mean, what the reason is that really the numbers of deaths were so much lower than in other countries. Of course, this is an interesting question, but it's always difficult to answer it because, of course, it's always difficult to also compare the countries with another. But yeah, of course, there were several measures in place, and also people reacted differently to these measures that were in place by the government. So I don't know if the Maltese people stick more to the measures that were imposed on them, but this is just yeah. So we really can't answer this question. For example, we had Norway. This was the only country in the whole Europe which had less excess mortality in the course of the pandemic. So they had lower numbers of deaths than in the years before, what is really a paradoxon, of course, and no one can explain it.
I think we were all very well behaved, Dr. Gatt, don't you think, especially in the beginning?
Yeah, yes, I think so.
I think
especially in the first year, I think the camaraderie between the different components of the population, and especially the elderly, and people wanted to protect the elderly. So I think the measures worked well. It is interesting to note, I believe that Sweden was the only country that did not have a lockdown. I'm not sure whether their mortality rate was high or average or low, I don't know.
It was actually indeed also lower, the excess mortality, but is also a paradoxon, of course. But especially for the Scandinavian countries, yeah, a lot of people think that this is because the country is so big and not so densely populated, of course. So this is also an explanation that they usually don't accept the main cities, of course, but there are a lot of regions where you have a low density of people living there, so they don't have so many contacts than people living in cities. But yeah, but of course, it's only a part of the explanation.
I think that requires a whole study and perhaps another webinar.
Look into that in detail. No, but I think with our high density in the country, people accepted it. I think there was not a lot from the public where they went against all the measures. I think there was a high acceptance, which actually helped. No?
Thank you for that. I don't know if there are any other panelists who would like to react to Ms. Peters' presentation before we actually kick off our panel discussion, where we're going to really focus on the national situation. No more raised hands, so I believe we can kick off. Thank you, Ms. Peters. Oh, here, Mr. Rizzo. Yes.
Unmute myself?
Yes, please.
Okay. And first of all, thank you very much for the information. I cannot put my camera on, but if you're hearing me, I can continue.
We can. I think you should accept your invitation to rejoin as panelists, because otherwise we cannot see you. Okay.
Here, I don't know. Oh, here I am. Let's see. Okay. So
there you are. We can see you.
I'm a little bit in the dark, but the situation is this. Yes, interesting to hear Miss Laura and Mrs. Alul, and also Mr. Gatt. From my side, I come, apart from being a representative of the Economic and Social Forum, representing NGOs. Really, my expertise as an accountant is in, obviously, taxation and education. So, but anyway, I do follow. What I can say is, from perhaps my experience as now president of the Federation of Professional Associations, is that most professionals have been under pressure for quite some time, especially the frontliners, doctors, nurses, pharmacists, and you know, healthcare people who are involved in healthcare, physiotherapists, etc., etc. So I think the effect on the professionals will hit Malta at a later stage. I think at the moment everybody is going on and trying to do its utmost to solve the issues, but when I think the pandemic will really go, the pandemic numbers will really go down, then we can start seeing the effects on professionals. One interesting point is that what I got from my colleagues is that when it comes to psychologists, they saw an increase in the number of interventions that they had to do, because people were closed in. For instance, my mother, who is in a home, has been closed in for 15 months. And if it wasn't for instance, giving her a phone where she could see us, then, you know, I don't know if she would have survived that long closure in a home. But now she's well, you know, a lot of people are recovering, but I think we have to see exactly what happens to the professionals who are frontliners. I think the effect will come at a later stage. Obviously, the precautions taken by government and by the health sector were good. I agree to practically all of them. Perhaps there could have been better understanding of accepting people coming to Malta who were not fully vaccinated. I think that might have added a little bit the numbers in Malta. But all in all, I agree that the situation was very well taken care of, and that, as Mrs. Alul said, the population took care of themselves, took care of their health situation, and helped by taking all the precautions necessary. Regarding professional, I think in Malta, what we need is perhaps better specialized units apart from the main hospital to take care of special areas where there would be then a relief on the main hospital, which I think at the moment is overworked. Thank you very much.
Yes, I believe that was also reflected in the country-specific recommendations. If I may, I would really like to start zooming in on the actual reforms and investments within component number 4 of our recovery and resilience plan. And in relation to this, perhaps I can come back to you, Dr. Gatt. Can you, and Ms. Peters already touched upon them, but maybe you can give us some further details about the actual measures that are envisaged under this component and what stage they're at, if they have already started being implemented.
Okay, by all means, by all means. In a short reply to Mr. Rizzo, it is, and he highlighted this point. Many people suffer from mental health difficulties and problems during the pandemic, and we saw this during, or rather, when people were being quarantined for 2 weeks, and initially even for more than 2 weeks, because the initial quarantine period was 28 days for the first few weeks. And we offered psychological support and social worker support, and even mental professional support through our mental health services and also the Richmond Foundation. So I must thank these services. Yes, you asked at what stage are these services being. So I think there are 6 or 7 questions that you had put on the list. Shall we work through them one by one, or?
No, just the first question at this point. So within the health policy framework, okay, and then the actual measures within the recovery and resilience plan.
All right, so yeah, I can understand. I can answer that, yes. With regards to the health policy framework, we have a policy, I've been going through it the past 2 days, which is prepared. It is at the stage where it needs to be reviewed by the Minister for Health. After that, it will move on to a wider consultation phase, and then the final policy will be finalized and published. How we do these sort of policy documents or frameworks, we consult the relevant entities when at the initial phase of the process, and then the policy is written, and once that is written, it is then it goes out to the wider consultation phase and even to the public. So that's the phase it is in.
Okay, so there has already been an initial level of consultation, I understand.
Yes, you can say that, yes.
Okay, thank you, Dr. De Guara. Maybe I can come to you, hear your reactions to what has been said so far, and also to Dr. Gatt's comments.
Yes, thank you for inviting me over, and thank you for the very well presented presentation. From my point, obviously, I come from a background of a family practice, mostly in the private sector. I've worked both in public and even in private, but obviously I am fully fledged as a private. It was interesting to note also that there is a decrease in the amount of general practitioners, even as said in the presentation. And I think nowadays that is also a very big problem we are facing. I am also on the assessment as a medical doctor to assess new inputs of general practitioners onto the market. However, I must admit that we are finding it very difficult for certain individuals to pursue a future and a career in the private market. I think 2 main factors. One is the factor when government issued a contract A and a contract B service system. So the newly graduated would be more inclined into going with government for better job security, better stability, better backup, rather than going into a fully fledged private market sector. It is also interesting to note that when I had even done a thesis on family practice in the private sector, although Malta has both a private and a public sector, still the highest amount of individuals seek the private market sector. So be it for a normal GP consult, be it for a specialist treatment, they prefer to go privately rather than outsourcing into the government sector. I must say that, yes, we have seen major improvements from government and even digitalized health. I think we were always saying this in the health sector has to have an input of digitalization, but paradoxically, I think it was the pandemic which got them kick-started to really invest into this sector, which I have to say that our colleagues in public health have done a sterling job. One point I would like to also point out is that even though public sectors like the primary healthcare in government have offered telemedicine and have also offered a free service, I believe, coming also from the private sector, that this was not highly informative towards the general public. So we still have an aging population, and we have to not forget those aging population who are not too digitalized oriented. So it's one thing saying, listen, we have gone digitalized on certain issues, but we really have to bring that home to the major of the population. We are also having another input into our system from a lot of foreigners. So most of our health sector workers are foreigners, basically, coming in from other countries, and we have to see to their needs also, because that is something I think it's going to be challenging for our health sector system. It was also interesting to note that, listen, the policies are being encouraged and are being taken into consideration, which I am very happy to see that. What I think we should really do is that we have to try and find liaison between the private sector and the public sector. I think in today's world, putting everything or dishing everything onto the public sector is even more costly sometimes than dishing it out onto the private sector. So I think we have to change the idea of government, listen, let's go and invest more in the public funding sector, opening up more clinics and whatnot. I mean, I think the easiest in the health sector is to open up new hospitals, new clinics, new services. The biggest challenge is finding people to work into those sectors. And I think Malta, the advantage that we're basically an island, well, we're even, I think, as small as some cities, that we have such a good private sector market that I think if government really sits down, obviously I'm from the Chamber of Commerce section now, that if government really sits down and we really try and find a unity between both sectors, I think that the end product towards the client, they will have a better product, and even sometimes it can even be cheaper if government really takes on board the private sector. So I think this is something that we should really look into.
In fact, yes, Dr. Degor, I think you preempted my next question because a lot was mentioned also in the initial presentation on prevention. So my question to you and also to the other panelists was, how do you see that the private sector can contribute to this tangibly in terms of increasing our efforts in prevention?
Well, I think prevention, the most important thing that one can actually do is that we have to get an awareness into our community and even our population. Mm-hmm. So let's say we have seen that obesity is the #1 cardiovascular disease, and all these are sectors which Malta fares very high on problems to them. So I think prevention is the key. It will take time because obviously it's very difficult to change attitudes of a nation, let's put it this way. And let's say if we're taking obesity, it's one thing telling people, listen, go healthy, eat healthy. But then when you look actually on the ground where we actually work, eating healthy is more costly than eating, let's say, fast food sometimes. So that is an issue where I think we really have to target. So it's easy to tell everyone, listen, go healthy, eat your veggies, eat your stuff, when we know that the major community finds it challenging in order to try and go onto these type of prevention. Now, I think if we invest heavily in marketing, in the sense that we inform clients, we try and even see how we can get a healthy lifestyle which is affordable for most. In the future, it will be even more economic towards the nation, because if we manage to prevent most diseases, then we will be reducing the load on both the public and the private market, as well as obviously bringing the life-being of the individuals to a higher level. So I think that is my honest opinion about this.
Thank you so much. I see that Dr. Gatt would like to react. I think you are muted, Dr. Gatt. Dr. De Guara, sorry.
Sorry, apologies. Yes, I concur to what Dr. De Guara has said, and we know that we have this particular divide, social and economic divide in the country, where there are two main socio-economic groups: the well-educated and high socio-economic group, with less mortality, less smoking habits, less alcoholism, and they usually fare much better in terms of lifestyle and chronic diseases. Whereas we have the lower socio-economic group, which is less educated. And it is this lower socio-economic group that is carrying the burden of obesity mostly, overweight, smoking, alcohol, and other, and even sexual behavior, which is not really acceptable. It is not saying that the higher socioeconomic group does not have these habits. What we are seeing is that there is a divide of about 30% between the two socioeconomic groups in terms of survival, in terms of prevalence of chronic diseases, etc. And the greatest challenge is to reach the lower socioeconomic groups. If you are educated and you know how to use a digitalized system, and you know how to access the internet and to positively contribute to your chronic illness in terms of knowing about it and in terms of learning to deal with it, is different from the lower socioeconomic group, which many of them cannot reach or do not have the capacity of digitalization access. So so far, we have over the years seen the success of what we call the discharge liaison nurses and midwifery schemes, and in terms of trying to reach this section of the population, we plan to address obesity and dietary problems, etc., in terms of more direct outreaches to this group of the population, the subgroup of the population. We need to, there are plans rather, to study ways of working with kindergarten levels, with primary schools, etc. We need to reach these people very early on in life. Once a child is already obese by 7 years of age, it becomes very difficult for that individual as the individual grows over the years to lose or to change the habits. So we need to teach these habits very early on in life, and we need to find ways to do this. The private sector might, in my opinion, might try to find ways of assisting in this direction, in the sense that collaboration or collaborative ways can be found between the government and the private sector in working on, for example, good nutrition, exercise, good habits in life, etc. So we will, and we are trying to plan for these. It is good to say that, yes, what Dr. Teguara said is that we are losing over the years the older GPs in the community. And this is a default, perhaps, of the system as it is, as he said. Now, the way things have developed, but we need more GPs in the community. People, well, not necessarily prefer, but very often when they go to a private GP, it is because they do not want to go to a health center and wait in the queue, or because the general practitioner is only a short distance away from their house, or because the general practitioner is a family practitioner and has known the family for many, many, many years. So these are the positive aspects of being a GP. Perhaps also the general practice is not offering that much of good remuneration in terms of private practice. I'm not sure about that, but we can improve on that, certainly. And we also might propose ways of the government assisting private individuals or in their private consultations. For example, instead of the government taking all the load of general practice, which is not certainly much something that we desire, but we can, the government can sort of give a payment to a portion of the payment of a consultation. That is something which needs to be studied and in the future, and we'll have to see. Thank you.
Thank you, Dr. Gatt. Just to remain on the topic of the workforce now within the health sector, I believe that Ms. Peters touched upon this topic as well in her presentation. So in terms of creating a stronger workforce, what needs to be done? And how can employers, both public sector employers and also private sector employers, turn this goal into a reality at the end of the day? Maybe, Mr. Rizzo, maybe I can direct this question to you.
There it is. Thank you. Yes, I was going, that's why I raised my hand. Well, as we are seeing it from studies that we have done at university with university students and sixth formers, and also when we asked certain people, excuse me, because the phone is ringing, just killed it off. Usually it happens when you start talking. Well, we are seeing that given the size of the population and knowing that we have practically all the people who want to work are working, it seems that people are choosing in which profession they would like to be involved in. And we are seeing that, yes, the number of, for instance, of doctors, engineers is dwindling. The number of people starting courses at university is dwindling in these areas, because they are preferring to go in other areas. Not so much in other health areas as well, not so much in the areas where there are the doctors, for instance, and the pharmacists mostly, because I think numbers are dwindling there. It's difficult. It's difficult. So we have to rely on offering packages from perhaps professionals outside Malta to come and practice in Malta for perhaps a number of years, 5-year, 10-year term. But this is what we're seeing, that the number of people trying to go in university to study for much needed professionals, I think, is dwindling. And we have to look and see why this is happening, because in the past, I think people wanted the first choice for people with high marks at high marks entering university were for doctors and lawyers. This has changed a little bit. I'm an accountant by profession. Accountancy profession has increased enormously, but I can see that the engineering profession can increase, but we are seeing that the number of people going in engineering is dwindling. So, things are happening, and perhaps we need to perhaps spend on more time on educating people and how to choose careers, because I think in the long run we need the doctors, we need the dentists, we need the pharmacists, perhaps more than the lawyers. I don't know, because lawyers now are even specializing. You know about that. My daughter is a lawyer, but she's specializing in intellectual property, so not so much going to the courts. But this is what is happening. People are finding their niche where they can work and they can contribute to what they would like to do with their lives. And I think we have to study at that level. So we have to rethink education. Thank you.
Thank you for that, Dr. De Guara. May I come to you for your take on this?
Yes, I think I tend to agree that our profession and other professions are dwindling. But from my aspect, or the way I see it, is that one has to also look into job security and job satisfaction. When it comes to the health sector, unfortunately, whereas before it was a prized work, saying, listen, I'm a doctor, I'm a lawyer. Nowadays, unfortunately, you find job security and even job opportunities in other fields, which gives you a better stability, I would tend to say, and even satisfaction. So we have, let's say, pharmacists were mentioned, whereas before the pharmacist, it was, let's say, a profession. Nowadays, a pharmacist has become another vending person in the pharmacy. Number one, before, pharmacists used to be involved in actually mixing components, whereas today it's just this selling off the counter. Even though, so many pharmacists today go into Q&As with private companies, because obviously they have much more job security and even job opportunities in that sector. So we are losing a lot of the community pharmacists. And even if you actually speak to people who own or actually run pharmacies, their number one headache is, listen, how can I actually find a pharmacist to do a locum? Whereas before they were easy, nowadays it's become difficult. When it comes even to the health sector, I tend to see that job satisfaction has dwindled. And now it has dwindled because the workload has increased, both with government sector. I think even there is job stability for sure. There is job security, no doubt. However, when it comes to satisfaction, then it's a bit of a different area. I remember the days when I used to work in the public sector as a GP. Job satisfaction was close to zero, for the simple reason that, number one, people just come to you just to get a quick fix, and they are not really interested in follow-ups. And I think even my other colleague has just mentioned in the private sector, people keep choosing the private over the public. I think for the simple reason that they are actually coming to an individual who knows their history, and they know that the next time round they are going to find the same person. Whereas we find it very different in the public sector, where today you're seeing Dr. X, tomorrow you're seeing Dr. Y, and the day after you're seeing another colleague. So I think for a long-term effect, that is something that one has to look into. Regarding how to entail more people into fields which are dwindling, I think one has to actually see how we can actually help them out, in the sense, is it just by increasing a pay? Is it just by increasing stability or security? I think it's more about job satisfaction, which we have to work upon, rather than other areas, for the simple reason that many individuals are not choosing our profession, for the simple reason that you can find other professions which you can go into, which probably give you a better pay for less work, in the sense that, listen, it's 8 to 1 job, and then after that job you're free to do anything you want. Whereas in the medical field, it's a bit of a different issue there. Also, I think the fact that we see doctors who work both in the private as well as in the public, I think we also have to look into that and why that is happening. Because I think when you look at the foreigners, basically doctors working in UK, in other countries, they usually just stick to one job with government, and they do not even look into the system of, listen, I'll work privately. Also, I think something we have to look into, that over here, the private sector is a no man's land. So you're a sole person alone. Whereas other countries, like other EU countries, there are trusts and the government which actually offers a good financial package towards these systems, which even helps them invest and also expand their services more towards the client. So I think there are multiple factors we can look into to see how we can actually improve. I don't think it's just by guiding individuals, because you can sugarcoat it any way you want, any profession, but at the end of the day, the individual will see what he wants out of the profession, and I don't think that sugarcoating any profession will get them going. Let's say many even lawyers today have gone into EU fraud and whatnot, because that is where the sectors want to go. And maybe court, whereas before court used to give a kick to most lawyers, nowadays it doesn't seem to be the preferred choice. So
yes, I think that resonates with many different professions. Thank you for that. I'm very conscious of the time, so if you allow me, I'm going to move on to the next question, because I really want to be able to cover all the different aspects of the recovery and resilience plan. And there was mention, even in Laura's presentation towards the beginning, of a blood, tissue and cell center. Dr. Gath, I think perhaps you can answer this one. What is it for the ones who are not medical, so we don't really understand what this is, and why is it needed?
Thank you for giving me the floor. Yes, we have currently a new center being built for blood, tissue, and cell, as a blood and tissue and cell center. It is important at this stage of development of our health system to have this center. We need this center in order to be able to store and use it to store body tissues, blood, tissue, cell centers, and also in order to use it as a banking system for tissues coming from the human body. For example, we can become almost self-sufficient with regards to plasma-derived products when we have this center. We need this center also to store stem cells for stem cell transplantations, HLA typing and tissue banking, cornea, bone, skin and tendons. This is necessary. For example, if we need to do HLA typing, which is necessary before an organ is transplanted in Malta, okay, we have currently difficulties in doing so. And so we need to rely, where necessary, on foreign laboratories. And so we need to move, if we need to develop further organ transplantation properties, we need to this center. It is important to say that along with the center, we already have the necessary legislation in place. And most of this is EU legislation, which has been transposed over the years. For example, we have the Blood and Transplant Acts of 2006-2007, Tissues and Cells of 2014, Human Tissues and Cells of 2007, etc. So there is a host of legislation which is already in place. Some of the legislation has been created by Malta, but most of the legislation is transposed directly from EU legislation. So to speak, the framework, the legal framework for this center is now already in place.
Okay, and the actual setting up of the center, is that underway already? Because I understand this is a substantial investment within the plan, right?
Yes, it is already in place.
Okay, thank you for that. Dr. De Guara once again, and also Mr. Rizzo. There was a lot of focus on digitization within the health system, both in Ms. Peters' presentation, but also during our discussion so far. How is this going to make our health system more resilient? Because the topic, after all, is that, it's resilience.
Who goes first? Dr. De Guara?
Go ahead.
Well, digitalization has become very important, especially COVID has opened up this area to most professionals. And many professionals like myself, for instance, when I want to talk with my colleagues, usually we do it virtual because it's easier, more convenient for us. We do what we have to do. We pick up the right time. We spend an hour. We discuss everything in 1 hour. So even in our thoughts and the way we act between ourselves, we try to be as synthetic as possible, not to go over the time limits that we would have established ourselves. So setting a meeting for my maximum meeting is 100 minutes. Usually I go for an hour, but when there is other things to discuss, I say after 100 minutes, everybody is tired and no new ideas come along. So yes, digitalization has helped, as I said before, certain, for instance, psychologists turned to digitalization and doing work via a computer.
Yes.
More than perhaps other because they could do it. For instance, a physiotherapist cannot do the work virtually. He has to be there. And speech language pathologists, whatever, they have to be there. Although certain work can be done. I would just want to add one point, what Dr. De Guara said about pharmacists. 12 years ago, 14 years ago, I also thought that pharmacists were there to sell you a product which they have in the pharmacy. The Chamber of Pharmacists have done a lot of work in this direction, and now when you go and buy, or the doctor orders you some type of medicine, when you go to the local pharmacist, they will ask you why you're going to take it and if it's the best, or else phone your doctor again in front of us so that we can help him, so we can help you so that you choose the right medicine. So I think the stigma that was stuck with certain pharmacists is going down. Also, I happen to know pharmacists who are now working in laboratories, okay, medical laboratories, and also food laboratories. So, you know, the pharmacists have tried also to find a way outside pharmacies, because, as you know, there is this rule that you cannot have so many pharmacies in any town, depending on the population. So the whole situation changed even that profession of how they work. So I think, yes, digitalization will definitely work better. In fact, I am being asked to give my opinion virtually to my foreign companions, and because I tell them, no, it's no use traveling, spending what 7-8 hours going to a place and coming back, while you are all only have to speak for or have a panel for 1 hour. So, you know, that has changed even our mind for traveling and delivering. So I think, yes, everybody is being aware of the consequences, especially of COVID. But now, no, with the increase in fuel and with the increase in spending time in a hotel, etc., people are rethinking of how to utilize their time. I think this is important. Thank you.
Thank you, Mr. Rizzo. Dr. De Guara, back to you. The idea of digitalization in terms of developing our resilience.
I'm all out for digitalization, so that's no doubt. And as I said, I think COVID kickstarted it. But I think we really need to understand what we want by digitalization, in the sense that we do have already a digitalized setup in the government hospital, which is very helpful. Let's say someone who's coming into ER, we will take all tests and it can be seen by an orthopedic who's on call from his own home, let's say. So in that process, that has really facilitated a lot of stuff. Even if we're going to send a client abroad who requires treatment, then as medical professionals, we exchange all the stuff and all the files beforehand, before actually seeing the patient. We can also now access by listening to the patient, doing a consultation prior to him or her going abroad for treatment. So that is where digitalization has really improved. However, I have to be very blunt in this, where I think that we are still far ahead from bringing the public and the private sector together on this aspect. Let's say someone who is sent by a private clinic or a private GP towards hospital to do an X-ray can request an X-ray digitalized by ordering it online from his own mobile. So that is not an issue, and that has improved drastically. We have cut down a lot of paperwork. But when it comes to actually taking the image is not sent directly to the doctor who has requested it. So the only doctor or colleague who can actually have access to it is someone who's working in the public health sector. So the private sector, they have facilitated the effect of removing most of the paperwork to order the investigations, yes. But then if it comes to imaging, we have to wait for 7 to 10 days to actually get the result, not even the image. So I think if we really want that digitalization works, I think that it has to be accessible to each sector individually. I believe that many colleagues nowadays are capable because training has taken them quite well into training. They even have training in radiography and whatnot. So I think that being able to send an individual to the public sector to get an X-ray, which can be viewed instantly on the practitioner's mobile or PC, rather than wait for 10 days to get the result. I think that is where true digitalization would have taken effect. As it is right now, I think we're just touching on base that, listen, we have put into a digitalized system because we have cut down on paperwork. Fine, good, let's get going. But I think there is a lot yet to be done if we really want to get the full potential of digitalization. Also, both from people who work in the private sector and the public sector also, there should be a direct link. So rather than doing, listen, you can call your colleague who's on call, I think there should be a system digitalized, obviously, which can access, and people can see the image instantly, and there would be a 24/7 call between professionals. I think there is where then I would tend to agree that, listen, digitalization has taken effect and has also cut down a lot on the health sectors for the benefit of the patient. So I think that is where I see we have to get going. And I think now it's useless saying this we're working. I think digitalization is exploding in the system. And I think we have to keep going on to the speed that we have actually taken care of. Let's say public health have issued, and as my colleague well said, a very good system, which is now fully digitalized for COVID patients. So if it's as soon as one is positive, he receives an SMS, he receives a letter to tell him how long he has to stay there and whatnot. So I think that is where we really have to go. We have to really get a whole package of digitalized package to the end client, so that we would say we have achieved onto it, rather than getting bits and pieces and trying to listen. We've cut down on paperwork here, cut down on paperwork there. You know, that is where we have to really go. And also educating our nation on getting digitalized, because I think as yet we are still far off. Let's say many government sectors, people can pay their bills online, but when it comes to the older population, I tend to still see people actually not using this service and going physically there. So, you know, to pay their bills. So even though they have digitalized a lot there, we are still far from I think the achievement we wanted to achieve. Let's put it this way.
Dr. Gott, there are specific technological investments which are envisaged under the plan, correct?
Yeah.
Maybe you can just give us very quickly an overview of what these are.
Yes, you are correct. Yes, in practice, we are working and we are planning also digital applications, and I will mention a few examples. The primary healthcare has now launched the electronic patient record system within the department. This is already being showing that it is effective. It is also carrying the patient record, so that eventually paper-based records will be eliminated. And so there is more continuity between one doctor and the other, or one clinic within the primary health centers and the other. It will also eventually be integrated with the rest of the IT systems in modern-day hospitals, let's say the laboratory information system, the medical imaging system, appointment system, etc., as well as the other e-health services such as immunizations, medications, and e-prescriptions. So the EPR is a very good step forward. Of course, as Dr. Deguara said, the digital literacy of certain part of the population or certain groups of the population is important, and we need to reach out to these people. There is also, as he mentioned, but not necessarily by name, there is the system, what we call the My Health system, which enables GPs, for example, to order radiography investigations, blood investigations, and which also transmits the results of patients, etc. We need to enhance this system further. So here I am following what Dr. Deguara has already said. Last year, I think it was in February or March last year, the government launched the remote patient monitoring program for primary for type 1 diabetics. This was launched for children till I think 16 years of age, if I'm not mistaken. And this has proved to be a very good system in controlling the blood sugar levels of insulin-dependent diabetes in young people with direct reference of the glucose levels to the hospital-based system in Mater Dei Hospital. And so the private sector here provided the necessary setup for this system to work in conjunction with the government system. So I think this is the way we need to move in the future, that the private sector enables and collaborates with the government system. And recently, this remote patient monitoring was, I think, yesterday or the year before, extended up to the 21-year-olds. Eventually, it will be extended to the rest of insulin-dependent diabetics. So these are examples of what we are working on. Of course, I must not fail to mention that in the future, and this already has started, we need robotic applications where robotic surgery for certain particular fields of surgery needs to be set up here. I think for prostate cancer, it is already set up. I'm not completely sure, but we are planning to extend these systems even further. Thank you.
Thank you so much, Dr. Gatt. I really wish to start wrapping up because I am aware that we are over time, but not before I ask the million-dollar question, and maybe we can have a round reacting to this question. The fiscal sustainability of the healthcare system. I believe it was mentioned in the country-specific recommendations. Mr. Rizzo, maybe I can start with you. What are we going to do about this? How are we going to ensure the fiscal sustainability of our healthcare system?
Well, thank you for this question. Yes, it is. Now, first of all, one has to look at how government looks at budget, expenditure, etc., etc. And at the moment, after an election, there might be a number of points that crop up to my mind. But obviously, government has to decide on priorities. I agree that priority one is education and health. So we need to understand that financing the education and health sectors are most important, because without health, there is no economy. And I think, but one has to say exactly, now that new administration is being set up, Parliament will start in 2 weeks' time. So one has to see exactly, but I think education and health for me are the priorities, have always been the priorities. And I think that government should look in these sectors very, very well and improve and stimulate these areas so that, more, especially in the education, especially we can only improve our fiscality and the way that we live if we have better educated people, and hopefully that the gap that Dr. Gatt mentioned, the highly qualified and the lowly qualified, will come very close to each other, because having people who do not know how to use computers, these are mostly the elderly, but giving them, like I did with my mother, giving her a phone where she could talk to us and see us, that helped her. So I think small things could go a long way. Thank you.
Thank you for that, and also for your participation, Mr. Tom. You have another commitment, so thank you so much for being here. Maybe back to you, Dr. Gatt, very, very concisely. I know it's a big question with many different dimensions, but if you can sort of summarize it in just a couple of minutes, your thoughts?
Yes, I think this is a very good question, and that we constantly ask ourselves here, and internally we discuss. Obviously, there could be ways of how the government can collect money, and then sort of, as we practice the system here, and redistribute it in a more equitable way. Obviously, it is important for the government to give the example of creating contracts that are open and not liable to criticism. So I'm not going into detail into that, but it is important that the country collects all the taxes it needs to collect, and from everyone, right? But we need also to protect those people who are unable to work, who for some reason or other, and we need to protect those individuals who, because of one reason or another, are also or have a very low income from day to day. So that is our responsibility. In terms of the Ministry for Health, we need to, in order to sustain health, we need to spend our money in a sensible way. And obviously, for example, we have, in a way, problems that when, let's go to the Mother Day Hospital, when we have lack of nursing staff, we ask our staff to do overtime. That becomes more expensive. So in a way, we need to ensure that we have sufficient staff to work with in our hospital. I think that's enough for me to say. Thank you.
Thank you so much, Dr. Gatt, as well, for your participation. And Dr. Daguara, your final thoughts as well on this question, on the fiscal sustainability of our health system.
Well, when you look at it, I think health is always an increasing expenditure. Year after year, the prices will still keep on going up with digitalization, with new technologies, with new robotic interventions. Any government will face an increased expenditure into this sector, which I believe should be still well sustained to have a healthy population. Yes, I tend to agree that government has to look into areas which will fund such a sector, irrespective, and also regarding not only funding in the sense of equipment, but even in the workforce. As was previously said, I think Mata Day suffers from workforce, although maybe people who are working right now say, listen, it's better because we're doing overtime, so we're getting extra amount. It will come to bite us back. People will break down, people will have enough of it, and even the quality of service will keep on deteriorating, in the sense that you can get someone to work 24/7, but then the productivity and the input he will be giving after a certain amount of time will dwindle, irrespective of the amount of money you will pay that individual. So I think we have to really see why we are having this problem with lack of nursing staff, lack of healthcare workers. We have to see where they are shifting, whether they're going to any other country, and why. If it is something that we can easily, let's say, arrange from a government system, then I do see that we really need to go into that direction. And I think hopefully like that, we should find the solution to the problem. The answer is not easy. There's no right and there's no wrong, but I think we have to stay on edge, see what's happening even in other countries around us, and see how we can improve to keep the very good professionals we have at any level, which includes a medical level, because obviously we're speaking about medical, to try and keep them on board. And both, I think, if we manage to keep them both work satisfied with a decent pay, then I think we won't have the issue of people leaving or working on burnouts and whatnot. So yeah, that's my view.
Thank you so much for that, Dr. Daguara, also for your participation. I would also like to thank Laura Peters and her colleague, Ms. Hendricks, for being here with us today, sharing their expertise on the topic. It was very useful for us. Thank you. And I will be wrapping up this webinar today. and also take the opportunity to inform that our next webinar will be tackling the topics of education and employment. And like this webinar and the previous webinar as well, it will be live streamed on our Facebook page in May. So thank you very much, and I wish you a pleasant day ahead. Thank you.
Thank you, everyone.
Thank you to all.
Thank you. Thank you.
Thank you.